Next, how long should it take to grieve the loss of a loved one? According to the DSM-5, the answer could be not as long as many of us might think. The American Psychiatric Association recently added prolonged grief disorder to their manual of psychiatric disorders to describe individuals who are experiencing, quote, an intense yearning or longing for or preoccupation with the deceased person. Their bereavement lasts longer than social norms and causes distress or problems functioning. The inclusion of this new diagnosis in the DSM will allow clinicians to bill insurance companies for treating it, which could be good news for people in mourning who feel they need help. But critics of the new diagnosis say it pathologizes a normal part of the human condition and that expecting bereaved individuals to just return to the way they lived before their losses on a strict timetable is unreasonable and unfair. So when it comes to prolonged grief disorder, do the positives outweigh the negatives? Megan Devine, creator of Refuge in Grief, joins me now, along with New York Times mental health reporter Ellen Berry. Thank you both for being here. Megan, as you see it, what are the implications of this diagnosis going to be for people who are bereaved in the years to come?
I think the impact it's weird because what does one little diagnosis in a clinical manual mean to the average person? And honestly, for a lot of the different mental health conditions that are listed in the DSM, we would never know about them. But with grief, with prolonged grief disorder, because grief affects so many people, and because we're starting to talk about this new diagnosis in the DSM, suddenly it's on everybody's minds, right? We're certainly still in the middle of a mass death and mass disabling event with the pandemic. People are grieving all sorts of things. So anytime we start having a conversation about grief in the public media, we start talking about what's normal and what isn't normal. And then we get this official thing from the medical industry that says that if you're sad or you're missing your person or you're having a hard time focusing, suddenly there's something wrong with you. So this is the real problem with something like prolonged grief disorder, especially when it hits sort of mass public media, is it doubles down on that message that having an emotional response to losing somebody you love should be cleaned up and over with really quickly. And you shouldn't be sad for longer than 6 months. You shouldn't be missing them or having them in your thoughts for more than a year. It just does such a disservice not only to grieving people, but also to friends and family who want to be supportive. And they're really being taught the wrong ways to do that.
Your work is deeply informed by the loss of your partner. What has your experience taught you about the way grief does and doesn't operate?
It's such a big topic. I think there's a lot of mystery around what grief actually is. And that's actually one of the big issues with prolonged grief disorder being an official diagnosis. If you look at the criteria, it says an emotional response outside of social norms. Well, what are social norms and who decides those social norms? We've certainly got a culture that is very deeply uncomfortable with emotion of any kind other than happiness, right? So we have this idea that sadness, depression, anxiety, anger, these are all sort of negative emotional states to be pushed through to get back to this normal health and happiness. So your question was like, what have I learned about grief, not only from my own experience, but from the last 10 years of listening to millions of grieving people and having them say, I feel like I'm the only one who feels like this. I don't know if I'm normal. My friends and family expected me to go back to my sunny, rosy, productive, hardworking personality that I was 6 weeks ago before my baby died. And we just have such a deep misunderstanding of grief, which is really a misunderstanding of what it means to be human, because all of us grieve something. So what I've really learned over the last 10 years is that the difference between our sort of medical, clinical ideas of what optimal human mental health is versus the lived reality of most people, they're two very, very different worlds. And you take something like prolonged grief disorder as this edict from the industry that says there's a right way and a wrong way. And then you've got the normal human whose sister just died of breast cancer or your parent died of COVID, and I'm supposed to be performing to a certain level of mental health and wellness on a very strict timetable, and that's not how I feel.
Yeah.
Yeah.
Ellen Berry, you talked with proponents and critics of the new diagnosis for your piece, which I have seen circulated everywhere. It seems to be driving the discussion to a large extent. What did the people who think that this is a useful thing that will provide assistance to individuals who are suffering, what did they say to you to make their case?
The people that contributed to this decision and worked on it over a period of many years would say that it's a diagnosis that should apply to a very relatively small slice of people. So they say, I've heard 4%, I've heard 7%. So it's identifying particularly acute sufferers. And the way they describe it is this sort of persistent stuckness in pining and yearning and ruminating. So a bunch of pattern behaviors that we all go through when we have a traumatic loss or even a loss. But in this slice of patients, of people, of grievers, they weren't moving past it. And so for this 4%, some treatment may help. And that is the group that they're looking at. I think what's complex here is that when you define what's abnormal, you're also defining what's normal. And because, as Megan said, so many of us have had this experience ourselves, and the first thing we would say is that it's mysterious. It unfolds in ways you can't predict. And it's so human and it's so painful trying to draw some line between abnormal and normal. It's complicated.
It's a fraught exercise, right?
It really is.
Right.
Go ahead.
That said, when you hear the disorder, listen to people who have been diagnosed and treated for the disorder, they say, I was stuck. I couldn't stop thinking over the 3 days, while my child was suffering or dying, or I couldn't stop going over the experience in my head. Mm-hmm. And that this treatment helped them deal with that almost more as a PTSD type experience than a sadness experience. And I think that's something interesting, not only about the diagnosis, but about the therapies being suggested, is that they are more close to PTSD type therapies than depression therapies.
I went back before this conversation and looked at a piece that I did maybe 8 years ago. I spoke with a woman who was being treated for this in a trial program at Mass General Hospital when it was still a developing diagnosis. She spoke very compellingly about how this treatment had helped her out of a very, very dark place after the unexpected death of her husband from a brain aneurysm. One of the things she said she was able to do after getting this treatment, in the course of which she had this, to her, incredibly important conversation with him that she had never had before. She said it allowed him to integrate the memory of him and their life together in a way that she hadn't been able to before. She brought their belongings back from Europe, where they had been left after he passed away. She started putting pictures of him up around her home and remembering their life together in a way she hadn't been able to before. And when I reread that, it got me wondering, and I'll start here with you, Megan, and then Ellen, I'd love to get your thoughts on this. Is it possible that the assistance that this may provide for people who are in a very dark place could be a good thing, and the really problematic aspect of it is the definition, which you were talking about, Megan, a moment ago, telling people this is how it's supposed to be for every single one of us. Is that a fair analysis?
Yeah, I think that there are good elements in the diagnosis. However, how they're implemented and how they're used is pretty challenging. Actually, everything you just described, like this person came back and put photos of her dead husband up, in some ways that you could read the prolonged grief diagnosis, that would actually be a pathological thing, to put up photographs, to still be including that person in your life, right?
Yeah.
Who gets to decide what's pathology and what's normal? And that point, actually in the New York Times piece, I actually feel like that was one of the most balanced descriptions of the controversy. Normally they skew very heavily to yay pathology model. So thank you for that, Ellen. But this idea that is only supposed to apply to a very small percentage of the population, that I think that's wishful thinking. right? There is a small percentage of people who are grieving a loss who really, really cannot function. We're talking about activities of daily living, right? Having a hard time eating, sleeping, not getting out of bed, anything that would be like clearly distressing, not just impacting quality of life, like I can't stop thinking about the accident, or my appetite is really off, or I'm not sleeping. Those are all really normal parts of grief. They're messy, but they're normal. So for a small percentage of the population, or a small percentage of grieving people, yeah, they really, really, really deserve some extra support just to get through those activities of daily living. But that's not what the language of prolonged grief disorder says.
And actually, I apologize for interrupting.
No.
Before I ask you, Ellen, I actually want to shift gears a little bit and ask you about the role that insurance coverage played in developing this diagnosis. But before we do that, to your point, Megan, some of the symptoms that are described in this new diagnosis, symptoms of prolonged grief disorder in the DSM, include identity disruption, sense of disbelief about the death, intense emotional pain, difficulty with reintegration, and intense loneliness, which to my eye are things that you might expect following a number of losses to exist for a lifetime. So my 2 cents.
Your 2 cents is right on with the lived experience of grieving people as well. You know, when you sort of take the psychological jargon out of that, what those things describe is sadness, missing them, wishing they were still here.
Yeah.
Right. When your parent dies, they stay dead. Right. There's no time that you're not going to miss them. If you hit a major milestone in your life, you're going to wish your dad was there. That is
I've done that
normal.
exact thing with my father. Yeah, since he passed away 10 years ago, and my own processing of it has been very uneven. It comes in fits and starts. A colleague of mine once said that she thought grief was like a plasma, and that has always stuck with me. For some reason, that metaphor works for me. Ellen, let me close with this question for you. To what extent was the development of this diagnosis driven by the way that we provide and fund mental health care in this country at this moment in time?
I think it was very much driven by researchers who are working on the problem, both working on therapies and also working on trying to define the problem, and had been working on it for 2 decades, really. And I think that's what pushed it through the system, their belief that they had a therapy that was really effective and that clinical trials showed it was effective. I think that's really what pushed it through. Of course, we do live in a world where clinicians need a DSM diagnosis in order to bill insurance.
Right.
And so that is part of the picture. It's also true that to get major funding for research into a condition, you need a diagnosis as well. So these are all part of the kind of economic structure of our medical system.
Which is also part of the problem, right? Because what foundation is the research standing on, right? If the research is looking at all of these displays of emotion, this expression of grief is actually a problem, and our goal is to erase all of that human emotion, then what is the funding and what does the research really look at?
I
So
would love.
I also think there's some concern that the pharmaceutical industry is going to start looking at grief as a target. And there's some drugs already in clinical trials.
Yeah, I can imagine the ads already, and I sort of don't really want to. I could talk to the two of you about this for another hour, but we have to leave it there. Ellen Berry and Megan Devine, thank you both for taking the time to talk this through.
Absolutely.